Assalamu alaikum students. I'm Dr. Amna Rafeel and on the behalf of Anatomy Department of Third Medical and Dental College, I welcome you all on my today's lecture, that is the gross anatomy of the peritoneal spaces. So students, let's move forward towards our lecture. So I hope you must develop a very fine concept about the peritoneum and about the details of the peritoneum up till now. So I'm here just starting my lecture with the general arrangement of the peritoneal cavity, which you must have studied some of it in your previous lectures. So the peritoneal cavity is a single continuous space between the parietal peritoneum, which was lining the abdominal wall, and between the visceral peritoneum, which is enveloping the abdominal organs. So it consists of the greater sac, which is the main peritoneal cavity surrounding most of the abdominal and pelvic viscera, and the lesser sac or mental bursa, which was a small diverticulum situated behind the stomach and the lesser omentum in the pancreas. These two sacs communicate by the epiploid foramen. So you see over here, this is Jattal section showing you all the peritoneal cavity between the parietal peritoneum that is lining the abdominal and the pelvic wall, and the visceral peritoneum that is enveloping the viscera. So between them is the peritoneal cavity. So this cavity had two parts, the greater sac, which was the majority of the part that was lining the abdominal and the pelvic cavity, and it has a smaller part, a diverticulum present behind the stomach and the lesser omentum, that was known as the lesser sac. These two sacs communicate each other through the epiploid foramen. So for the clinical purposes, the peritoneal cavity is divided into several spaces, and pathological processes are often contained within these spaces, and their anatomy may influence the diagnosis and treatment. So it is quite helpful to divide the peritoneal cavity into two main compartments. Those are the supramesocholic compartment, often known as in a simple words, that is the supracollic, and inframesocholic, or known as the infracollic, which are partially separated by the transverse colon and its mesentery. So students, what happens that for the clinical purposes, the peritoneal cavity, we divide them into, this peritoneal cavity has several spaces, and these spaces are the potential sites where the inflammatory fluid can accumulate. And to know the anatomy of this spaces will of course have an influence in the diagnosis and treatment of the condition which lead to the accumulation of fluid in those spaces. So for the clinical purpose, we divide this peritoneal cavity into two parts. The part of a peritoneal cavity that lies above this transverse colon and transverse mesocolon is known as the supracollic. Supracollic means, supra means above, and colic is derived from the large intestine, and that is the transverse colon. So above the transverse colon and the transverse mesocolon is supracollic compartment, and below the transverse colon and the transverse mesocolon is the infracollic compartment. So these both compartments will be having peritoneal spaces, which are the potential sites where the inflammatory fluid can accumulate, or any pathological process can be contained within those spaces. So here is a schematic flow chart just to show you how we divided the peritoneal cavity into various compartments. So of course students, you know that the peritoneal cavity is lining the abdomen proper and also extending into the pelvis as well. So within the abdomen, this peritoneal cavity is being divided into two compartments, so supracollic and infracollic, and as I have mentioned in my previous slide, these two compartments are divided through the transverse colon and the transverse mesocolon. So the peritoneal cavity lining the abdomen proper is divided into two compartments, supracollic and infracollic. The supracollic and infracollic, they are being divided by the basis of transverse colon and transverse mesocolon. The supracollic is further divided into right and left by the attachment of falciform ligament. I will explain you in the next slide. While the infracollic compartment is divided into three parts, the right and the left parts are divided on the basis of the root of mesentery. The part lying on the right of the root of mesentery is the right infracollic, and the part that lies on the left of the root of the mesentery is known as the left infracollic, while the part of the infracollic compartment that lies on the lateral aspect of ascending and descending colons are known as the paracollic gutters. As the name indicates, paracollic, para means around and colic is the large intestine. So the portion that lies lateral to the ascending colon and the portion that lies lateral to the descending colon are known as the parabolic gutters. So this was all the divisions that included in the abdomen proper. While the peritoneal cavity, which is extending to the pelvis, is also containing the peritoneal spaces, which differ both in males and females. So in the males, the peritoneal space is known as the rectovesical space. So students, there are other spaces as well, but we will only focus in this space, while the rest of the spaces will discuss when we will study the pelvis in a proper way. So in males, the peritoneal space is known as the rectovesical, and the name indicates recto is derived from the rectum, vesicle is derived from the bladder. So the space between the rectum and the bladder is known as the rectovesical space. While in females, the spaces are 2 in number, which we are going to be study in focused point. So those are the rectouterine and the vesicouterine. The rectouterine, as the name indicates, between the rectum and the uterus, and vesicouterine, as the name indicates, lies between the bladder and the uterus. So the peritoneal cavity lining the abdomen, abdominal cavity has 2 compartments, supracolic, infracolic, which are further divided, while the peritoneal cavity extending into the pelvis has peritoneal spaces which differ in male and females. In the males, it is the rectovesical, and in females, it is the rectouterine and the vesicouterine space. So let's start with the supracolic compartment. So supracolic, as the name indicates, supra means above and colic is derived from the transverse colon. So supra over here, you see this above, lying above the transverse colon, the transverse mesocolon is known as the supracolic compartment. It lies between the diaphragm and the transverse mesocolon. So this is the diaphragm and this is the transverse colon, and here will be the transverse mesocolon. So it lies between the diaphragm and the transverse mesocolon, and the attachments of the liver to the diaphragm and the abdominal wall will define the subdivisions of supracolic compartment. So if you remember in my previous lecture, I explained you that there were several peritoneal ligaments and reflections around the liver, which were attaching the liver from the anterior abdominal wall as well as to the diaphragm, and those were the coronary ligaments and the falciparum ligament. So this falciparum ligament is dividing the supracolic compartment into right half and the left halves. To the right of the this interrupted line is showing you the attachment of the falciparum ligament. So to the right of the falciparum ligament will be the right subphrenic space and the left subphrenic space. So this is the right subphrenic space and there will be the left subphrenic space. And of course, we have the right subphrenic and we have right subhepatic, and we have the left subphrenic and we have the left subhepatic spaces. So if we classify those spaces, then they will be known as the right anterior space. So you see, also known as the right subphrenic. Subphrenic means below the diaphragm. So right subphrenic space on the right side below the diaphragm is the right subphrenic space. And the right posterior space is known as the right subhepatic space. So subhepatic means it's below the liver. So you see this over below the this right lobe of the liver, this will be the right subhepatic space. On the left, there will be left anterior space, also known as the left subphrenic space, will be between the diaphragm and the left lobe of the liver, while this left posterior space or the left subhepatic space is lying over here, just below this right left lobe of the liver. We will discuss those spaces in bit detail in the next slides, where those spaces are located and what clinical significance those spaces are having. And students, out of these 4 spaces, this right posterior space or the right subhepatic space is the most important one, and it has quite a huge weightage on the examination point of view, and we will discuss it in detail as well. So let's start with the details of supracolic spaces. So supracolic compartment was the part of the peritoneal cavity which was lying above the transverse colon or mesocolon, and that supracolic compartment was further divided by the attachment of the falciparum ligament into right and left spaces. The right space had 2 parts, that is the right anterior and the right posterior, while the left also had 2 parts, that is the left anterior and the left posterior. So starting with the left anterior space, also known as the left subphrenic space. The subphrenic word means below the diaphragm. So this space is also known as the subdiaphragmatic space. So it lies between the left lobe of the liver and the diaphragm, in front of the triangular ligament, and inferiorly it extends to the front of the lesser omentum and of the stomach, and towards the left it reaches the spleen, and an abscess may form in this space following the operations on the stomach, the spleen, the splenic flexure of the colon, and the tail of the pancreas. So students, this space is known as the left anterior space, also known as the left subphrenic space. As you can see, it lies between the diaphragm and the left lobe of the liver, in front of this left triangular ligament. So you see, this is the left triangular ligament, and between the diaphragm and this left triangular ligament is known as the left subphrenic space. So inferiorly it extends into the lesser omentum and into the stomach. So this place is the where from the stomach has been removed, and towards the left it reaches the spleen. Here the spleen is present, which is being removed. Towards the left it reaches the spleen, and abscess can collect in this space if there is any pathology that involves the spleen, that involves the stomach, that involves the splenic flexure of the colon, or even the tail of the pancreas. So the left splenic space, also known as the left anterior space, present between the diaphragm and the left lobe of the liver, in front of the left triangular ligament, and it inferiorly communicates with the it reaches the stomach, as well as on the left it reaches the spleen. And the abscess over here, the abscess in this area, they are usually derived from the pathologies that involve the spleen, the splenic flexure of the colon, the stomach, or the tail of the pancreas. So the next is the left posterior space, or the left subhepatic space. So this is the left subhepatic space, or the left posterior space, and it is also known as the gastrohepatic space, that is between the stomach and the liver. So this is merely the lesser sac. You see, this is also known as the lesser sac, which you have studied in your previous lectures. So the left posterior space, or the left subhepatic space, is merely the lesser sac. The right anterior, or the right subphrenic space. You see over here we had studied the left subphrenic, so over here will be the right subphrenic, also known as the right anterior space. So it lies between the diaphragm and the right lobe of the liver. In front of this, the liver has been removed. You see, this is the bare area of the liver you are seeing. This is the right triangular ligament, and this is the left triangular ligament. This is the superior layer of the coronary ligament, and this is the inferior layer of the coronary ligament. So this the right subphrenic space, or the right anterior space, or the subdiaphragmatic space, lies between the diaphragm and the right lobe of the liver, in front of the superior layer of the coronary ligament. So this is the superior layer of the coronary ligament on which my pointer is running, and this is the right subphrenic space, in front of this right triangular ligament as well. So this is all right subphrenic space, and the infection can spread to this space from the gallbladder, from the appendix, or if there is any surgeries that involve the upper abdomen. So appendix is lying over here, and how the infections are traveling from this appendix to this right subphrenic space is through the right paracolic gutter. So you see this space lying lateral to the ascending colon is known as the right paracolic gutter, and the infected fluid, inflammatory fluid from the appendicitis can travel through this right paracolic gutter and up to the right subphrenic space. Then we have the right posterior, or the right subhepatic space, also known as the hepatorenal pouch of Morrison. So you see, students, this space is known as the right posterior, or right subhepatic space, and this is also known as hepatorenal recess, and also known as the Morrison's pouch, and it is a very important thing to study, and it is important for your examination point of view as well, and we will study this in detail in the next slide. So before I jump to the hepatorenal recess, or the Morrison's pouch, the details of that peritoneal space, I would like you to explain a bit clinical relevance, which is related to the subphrenic abscesses. So what are the subphrenic abscesses? The subphrenic recesses these are the potential spaces in the suprapolic compartment. I mentioned you this in the previous slides. They are located between the diaphragm and the liver, that you know, and they are right and left, yes we know this, and separated by the falciform ligament of the liver. So the subphrenic abscesses refer to an accumulation of pus in the left or right subphrenic space. They are more common on the right side due to the increased frequency of appendicitis and ruptured duodenal ulcers. So the pus from the appendix can track up to the subphrenic space by the right parabolic gutter, as I mentioned earlier. So you see this diagram, this is the right subphrenic space between the diaphragm and the liver, and this right subphrenic space and there is the left subphrenic space. These are the potential sites where abscesses can collect. They are more common on the right side. Why? Because the right subphrenic space can communicate with the infraqualic compartment, as the inflammation from the appendicitis or the inflammatory fluid from the appendix can track up to the right subphrenic space through the right parabolic gutter. So let's start with our most important topic of today's lecture, that is the hepatorenal recess or the Morrison's pouch. So it is also known as the right posterior space or the right subhepatic space. So it is a space between the liver and the kidney, as the name indicates, hepatorenal, which shows it's a space between the liver and the kidney. So normally this place is empty, but excessive fluid in the peritoneal cavity can lead to the fluid accumulation in the pouch, and it is a life-threatening situation. So students, this hepatorenal recess over here, you see the arrow, this is showing the hepatorenal recess, and this is the liver sagittal section and right lobe of the liver, and this shows a space, potential space between the right lobe of the liver and this right kidney. So this is the hepatorenal recess, also known as the Morrison's pouch, because it was derived from the anatomist who was known as Rutherford Morrison. So this hepatorenal recess, it has boundaries, of course. It's lying somewhere, then it must be having some boundaries. So it has an anterior boundary and it has a posterior boundary. It has a superior limit, it has an inferior limit, and it has the right extension and the left extension. So let's discuss the boundaries. Anteriorly, it is bounded by the inferior surface of the right lobe of the liver, and here the gallbladder will be present. So anteriorly, the inferior surface of the right lobe of the liver and the gallbladder. Posteriorly, you see over here, this is the right adrenal gland. So posterior relations are, the posterior boundaries are formed by the right adrenal gland, the right kidney, the second part of the duodenum, the transverse mesocolon, the transverse colon, and here near the duodenum will be lying the pancreas. So these are the posterior boundaries. So right adrenal gland, right kidney, second part of the duodenum, transverse mesocolon, and the transverse colon along with the tail, along with the part of the head of the pancreas. These are all forming the posterior boundary. So this was the anterior boundary formed by the inferior surface of the right lobe of the liver and the gallbladder. This was the anterior boundary, and this is all the posterior boundary. This superiorly, you see, this was the reflection of the peritoneum in front of the right kidney, the adrenal gland. If you remember my previous lecture, this was the inferior layer of the coronary ligament. So the superior boundary is formed by the inferior layer of the coronary ligament, and inferiorly you can see it is opening and communicating with the peritoneal cavity, with the general peritoneal cavity. So inferiorly it's open, and for the right and left margin, I will use the next slide in horizontal section. So up till now, what we studied, the hepatorenal pouch. Hepatorenal pouch, as the name indicates, it's a recess or a potential space which is present between the right lobe of the liver and the kidney, and which is normally empty, and it just opens when there is excessive peritoneal fluid or this inflammatory fluid which has been reaching this place from somewhere else. And it has boundaries, an anterior boundary, and it has posterior boundary, it has a superior limit, it has an inferior limit, and it has right and left margins that I will discuss with you in the next slide. So students, in this diagram, I can easily show you the right and left extremities of the hepatorenal recess, but first let us locate where the recess is located. So over here, this is the liver, and this is the right kidney, left kidney, this is the stomach, and this is the spleen, and this is the lesser omentum, and this is the lesser sac. This one is the lesser sac, and over here is the epiploic foramen. So this is this space between this right lobe of the liver and the kidney is known as the hepatorenal recess. And you can see on the right extremity, this recess is limited by the diaphragm. So there is a diaphragm, and on the left extremity, it communicates with the lesser sac through the epiploic foramen. So on the left side, it is communicating with the lesser sac through epiploic foramen, and onto the right, it is limited by the diaphragm. So let's discuss the clinical significance. So we studied that the hepatorenal recess or the Morrison's pouch is also known as the right posterior or the right subhepatic space, is a space between the liver and the kidney, and it's usually closed and empty. But in case of any pathology, like there's inflammatory fluid in the peritoneal cavity running, and this space can open up, and it is usually the most dependent part of the peritoneal cavity when the person is in supine position. So this is the supine position, and this supine position, the most dependent part, that is the most lowest part of the peritoneal cavity, will be the hepatorenal recess or the Morrison's pouch. The fluid coming to this hepatorenal recess could be coming from the major source. That could be the gallbladder, that could be the appendix, or that could be any other organ as well, because it has connections with the pelvis through the right parabolic gutter, and it is also connected with the left half of the suprapolic compartment as it is communicating with the lesser sac through this epiploic foramen. So let's spot the hepatorenal recess or the Morrison's pouch or the right subhepatic pouch in case of cadavers. So you see, students, it's not a very wide space, it's just a narrow recess, and it's usually closed. It just opens up whenever there is a raised peritoneal fluid or there is the inflammatory fluid being running in the peritoneal cavity, and this in that case, that this recess will open up to accommodate that inflammatory fluid, and that fluid will be coming from sources which we discussed previously, that it could be from the gallbladder, it could be from the appendix that is lying in the infracolic compartment, and that will be reaching this hepatorenal recess through the right parabolic gutter. So this yellow arrow is showing you the existence of this Morrison's pouch or hepatorenal recess, that is between the liver and the kidney, that is the hepatorenal recess. So this is the hepatorenal recess between the liver and the kidney. And this one is the right lobe of the liver, and this is the right kidney, and this is the gallbladder. So over here there will be the inferior layer of the coronary ligament, and this is the right kidney, and the space between this is known as the hepatorenal recess, and you see inferiorly it is opening into the right parabolic gutter. So students, before I move forward, let me make you one thing clear, that the spaces which we studied up till now, that were the supracolic spaces. So those were the spaces, those are the intraperitoneal spaces. So the intraperitoneal spaces means that those were the spaces which were surrounded by the peritoneum, while we have the extraperitoneal spaces as well, which are the portions of the abdomen and the pelvis which does not lie within the peritoneum, or these are the areas which are devoid of the peritoneum. So the extraperitoneal spaces means they will be out of the peritoneum. They won't be having peritoneum around them. So of course those spaces, it could be retroperitoneal, that is they could lie behind the peritoneum, or they could lie preperitoneal, they could lie before the peritoneum. So they must be present within the abdomen and the pelvis, and those present in the pelvis, we will discuss them while we study the pelvis. And those which are related with the abdomen are including the are as follows. That is the right extraperitoneal space that lies around the upper pole of the right kidney. So over here there will be no peritoneum. The left extraperitoneal space around the left suprarenal gland and upper pole of the left kidney, and this is the site for the left perinephric abscess. We will study this in the future classes. And then we have the midline extraperitoneal space, and that corresponds to the bare area of the liver, and that lies between the bare area and the diaphragm, and it is bounded above and below by the superior and inferior layer of the coronary ligament, and infection can spread to this space from liver, resulting in the liver abscess. So besides with the intraperitoneal spaces, there are extraperitoneal spaces as well, which are not surrounded by the peritoneum, and those include the right extraperitoneal, the left extraperitoneal, and the midline extraperitoneal, and out of which the midline extraperitoneal is the space that lies opposite to the bare area of the liver. So what was the bare area of the liver? That was present between the superior and the inferior layer of the coronary ligament, behind the right lobe of the liver, and this part of the liver was lying directly against the diaphragm and with no peritoneum intervening between this area. So the space between this bare area and the diaphragm, which was divided by the peritoneum, and that space is known as the midline extraperitoneal space, and infection can spread to this space from the liver, resulting in a liver abscess. So let's move forwards towards our infraqualic compartments. Infra means below, colic means the large intestine, that is the part lying below the transverse colon, and the transverse mesocolon was the infracolic compartment. So you see, this is the transverse colon, and the part below this is known as the infracolic compartment. So this was all supracolic, and this is all infracolic compartment. So it lies below the transverse colon and the transverse mesocolon, and you see this is the root of the mesentery running between this infracolic compartment, dividing this compartment into two parts, that is the right infracolic compartment and the left infracolic compartment. So the right infracolic compartment, it lies between, this was the right infracolic compartment. Over here you see this is lying between this ascending colon and the root of the mesentery, and it is triangular in shape, and the apex is directed downwards. So this is right infracolic compartment, triangular shape between the root of mesentery and the ascending colon, while the left infracolic compartment is present between this descending colon and the root of the mesentery, and it is also roughly triangular in shape with the apex directed upwards. And inferiorly you see the arrow showing inferiorly, it opens freely into the pelvis. So infracolic compartment divided by the root of mesentery into right and left. So students, let's move forward towards our next topic, that is the paracolic gutters, and that's a part of an infracolic compartment. And para means around and colic means the large intestine. So the paracolic means the two paracolic gutters, one on the right side and one on the left side. The right sided paracolic gutter lies lateral to the ascending colon, and the left side paracolic gutters lies lateral to the descending colon. The right paracolic gutter is wider and deeper as compared to the left one, and as you can see, it is freely communicating with this right subhepatic space, that is the Morrison's pouch or the hepatorenal access, and it further upward it also communicates with this right subphrenic space. So infections or the infected fluid from the appendicitis can travel up from the infracolic compartment through this right paracolic gutter towards this hepatorenal recess, or also can go to the subphrenic spaces as well, and that could be vice versa, that is the fluid from this subphrenic space and from this Morrison's pouch, or even from the lesser sac, as the lesser sac is communicating with this Morrison's pouch to this epiploic foramen. The fluid can go from this right paracolic gutter towards this pelvis, while the left sided paracolic gutter is lying lateral to this descending colon. It is narrow and shallow, and it is also limited superiorly by this attachment of the ligament that is known as the Trenicocholic ligament, that connects the diaphragm with the splenic flexure of the colon, and it is basically limiting this intracolic compartment, that is the left-sided paracolic gutter, with this supracolic compartment. But inferiorly you can see this left paracolic gutter is opening freely into the pelvic cavity. So students, let's come up with the second half of our today's lecture, that is the pelvic peritoneal spaces. We study the peritoneal spaces in the abdomen proper, and those were the supracolic and then infracolic, and then further they were divided. So coming up with the pelvic peritoneal spaces, that is the peritoneal spaces lying within the pelvis, how those spaces are formed, and those spaces differ in male and female. So what happens, how the spaces are created is by the reflection of the peritoneum from this urinary bladder towards the rectum in case of males, and the reflection of peritoneum from the urinary bladder to the uterus and then on to the rectum in case of females. So in men there is only one potential space, that is the rectovesical pouch between the bladder and the rectum, that is due to from the reflection of the peritoneum from the bladder towards the rectum. It creates a recess, and this is known as the rectovesical pouch. And in case of women there are two spaces, because the peritoneum is reflecting from the bladder to the uterus, creating a pouch known as vesicouterine pouch, and then it is reflecting again from the uterus towards the rectum, creating another pouch, another recess, and that is known as the rectouterine pouch, or known as the pouch of Douglas. So over here students, let's see those pouches in case of males and females in detail. That in the males, the rectovesical pouch is a double layer fold of peritoneum, and that is located between the rectum and the urinary bladder. And the peritoneal cavity in case of males is completely closed. So you see, this is the urinary bladder. The peritoneum is reflected from the superior surface, and then it is reflected in front of the rectum at the junction of middle 1/3 and the lower 1/3, and this reflection is basically forming a pouch, and that is known as the rectovesical pouch in case of males. Like in other case, that is in females, there are two potential sites, and those are the rectouterine pouch and the vesicouterine pouch. So the rectouterine pouch is a double folding on the peritoneum between the rectum and the posterior wall of the uterus. So you see, this is the rectouterine pouch between the uterus and the rectum, while the vesicouterine pouch is present between the bladder and the uterus. So the peritoneal cavity was closed in males. The peritoneal cavity in the females is not completely closed and the uterine tubes, because of the uterine tubes, they open into the peritoneal cavity, providing a pathway between the female genital tract and the abdominal cavity. So students, let's discuss the rectouterine pouch, or the pouch of Douglas, or the cul-de-sac, in detail. And it is, again I'm mentioning, it's very important on your examination point of view, and you must know what the pouch is, where it's located, and what are its boundaries, and what are its clinical significance. So the rectouterine pouch, or the pouch of Douglas, is also known as the rectovaginal pouch, and also known as the cul-de-sac or pouch of Douglas. It is an extension of the peritoneum between the posterior wall of the uterus and the rectum in females. It is the most dependent part of the peritoneal cavity when the body is in upright position, and is analogous to the rectovesical pouch in males. So you see, this is the peritoneum being reflected from the superior surface of the bladder to the anterior surface of the uterus, creating a pouch, and that is known as the utrovesical pouch. Then this peritoneum is reflected again onto the posterior surface of the uterus and from the posterior fornix of the vagina. So this is the vagina, and this is the anterior fornix, and this is the posterior fornix. So it is reflected from the posterior fornix of the vagina onto the front of the rectum at the junction of middle 1/3 and the lower 1/3, and this recess is being created, and this is known as the rectouterine pouch, or the pouch of Douglas. So if you remember this diagram, students, you can easily memorize the boundaries of the recess as well. So the boundaries of the rectouterine pouch are the anterior boundary. You see, this is the anterior boundary of the recess, and this is the posterior boundary of the recess, and this is the inferior boundary or floor of the recess. So the anterior boundary is formed by the uterus and the posterior fornix of the vagina. So this is the anterior boundary of the rectouterine pouch, or the pouch of Douglas. So this is the posterior surface of the uterus and the posterior fornix of the vagina. Then posteriorly by the rectum, of course, the rectum is lying behind the recess, and inferiorly you see this inferior boundary or the floor is formed by the recto-vaginal fold of peritoneum. You see, this was the peritoneum being reflected from the uterus and the posterior fornix of the vagina then onto the rectum. So this fold of peritoneum between this posterior fornix and the vagina and the rectum is known as the recto-vaginal fold of the peritoneum. So the recto-uterine pouch is a recess which is present between the uterus and the rectum due to the reflection of the peritoneum from the uterus and the posterior fornix of the vagina towards the rectum, and it has a clinical significance which I have discussed with you in the next slide. So students, let's discuss the clinical significance of the recto-uterine pouch. As it is the furthest point of the abdominopelvic cavity in women, in erect posture, it is a site where infection and fluids typically collect. So if you remember, I told you that in supine position, the most dependent part of the peritoneal cavity was the Morrison's pouch. While in the erect posture, that is when the subject is sitting or standing, the most dependent part of the peritoneal cavity would be the recto-uterine pouch in females and the rectovesical pouch in males. Plus, you can use this space, that is, you can use this recto-uterine space for inserting the catheter for doing the peritoneal dialysis in case of patients having end-stage kidney failure. So the patients who have end-stage kidney failure, they have to have a peritoneal dialysis. They have to have a dialysis, and that could be peritoneal dialysis, and that peritoneal dialysis can be done by inserting a catheter through the recto-uterine pouch. Plus, there is also another procedure you can do over here, and that is known as the culdocentesis. And culdocentesis means that is you are removing or you are extracting a fluid from the recto-uterine pouch, that is also known as the cul-de-sac. So that is why this procedure of extracting the fluid from this recto-uterine pouch is known as the culdocentesis, in which the needle is being inserted through the posterior fornix of the vagina, and this through this we can also put a drain to put a catheter, put a needle to drain the pelvic abscess. So students, the most dependent part of the peritoneal cavity in supine position is the hepatorenal pouch, and the most dependent part of the peritoneal cavity in erect position is the recto-uterine pouch in females and the rectovesical pouch in case of males. So students, let's watch the direction of the flow of the peritoneal fluid. So as you know that the fluid is pale and yellow, and it's viscid, it contains the leukocyte, and it's secreted by the peritoneum, and the purpose of secreting this peritoneal fluid is so that the visuras can glide on each other. So students, there are three factors which are affecting the flow of this peritoneal fluid. You can see in this diagram that the direction of the arrows is toward the cephalic position, that is, the flow is towards the diaphragm. And there are three factors that are affecting this flow of the peritoneal fluid towards the diaphragm, and those are the movements of the diaphragm, that is, the movement of the diaphragm will of course influencing the flow of this peritoneal fluid towards it, and the contraction of the abdominal muscles, they will also promote the fluid to flow towards the diaphragm, and the peristaltic movements of the intestinal tract, it also promotes the fluid the flow of the peritoneal fluid towards the diaphragm. Why they are going toward the diaphragm? Because there are the peritoneal lymph nodes, subperitoneal lymph nodes located under the diaphragm, which are responsible for the absorption of this peritoneal fluid. So majority of the, almost you can say the 90% of the peritoneal fluid is being reaching the subplanic spaces and under the diaphragm, where they will be absorbed by the subperitoneal lymph nodes. So you see in this diagram that the fluid from the pelvic cavity, it reaches the suprapolic compartments through this parabolic gutters. So fluid from the pelvis, it goes up to the right parabolic gutter and it reaches the suprapolic compartment, and where it can go to the right sub-hepatic space, that is the Morrison's pouch, or it could go to the right subplanic space. So from the right sub-hepatic space, it can also go to the lesser sac, as you can see the arrows going beyond, because the lesser sac and the sub-hepatic space, they are in communication with each other through the epiploic foramen. while the fluid can also reach to the subphrenic space, right subphrenic space, but you see over here that is attachment to the falciform ligament can limit the flow to reach from the right subphrenic space to the left subphrenic space, while the fluid from the pelvis going to the left parabolic gutter is being limited by an anatomical structure that is known as the Trenicocholic ligament, which does not allow the fluid to enter from the infracolic compartment to the suprapolic compartment. While the left subphrenic space over here you can see, and that could have the fluid accumulation in case if there is any pathology of involving the stomach, involving the spleen, or involving the splenic flexure of the colon. So the normal direction of the peritoneal fluid is towards the diaphragm, that is the cephalic direction, because there are subperitoneal lymph nodes located under the diaphragm which are responsible for the absorption of this peritoneal fluid. So students, I thank you all for your cooperation, and I hope you have understood very well our today's topic. So again, I'm giving you the nutshell of our today's lecture. That is, the basic two things where usually come in your exam are the hepatorenal pouch, and you must know what the pouch is, where it is located, what are its boundaries, what is its clinical significance. On the other hand, the pouch of Douglas is being asked frequently. You must know the location, its boundaries, and its clinical significance. So I hope you have understood very well, and in case of any queries you can still consult us anytime, and thank you and best of luck.